MNT2. Okay, so let's start our lecture today, Geriatric Nutrition. So this is the learning objective for today's lecture. So I believe that you already know the definition of the elderly. Okay, so we just do some recaps about the older adults. So what are the main challenges and the topic or just covered: malnutrition, overweight, and also obesity and dehydration. So what are the nutrition care process to apa to manage elderly patient, and what are the recommendation to prevent or to prevent and also intervene the nutritional challenges on malnutrition, overweight, and also obesity and also dehydration. Okay, so this is the guideline that I recently published in 2019, Aspen guideline on clinical nutrition and hydration in geriatric. So for today's lecture, I just focus on this guideline, and also I simplify. Okay, for all of you. So pernah tengok tak this guideline? We have any chance to go through, to download, to read? No, first time,
No,
yeah?
doctor. Yes.
First time. Okay, so why not after this lecture, you download the main document and read. So there are a lot of explanation, a lot of recommendation covered. Okay, the topic today just selected from this guideline only. Okay, so geriatric nutrition. Sorry. So older adults, is individual who are age 60 and older. Okay, so in Malaysia we use the cut off point of 60, and some of the country they use 65. Okay, Western and European country they use 65 because in that country people who age 60 to 65 is working, masih lagi bekerja. Okay, so but in Malaysia the pension age is 60. Okay, so the cut-off point is refer when the individual start to pension. Okay, so in Malaysia we use 60 and older. Okay, and the characteristic of the older adults ni, they have some of the characteristic. They have a high degree of fertility. They have the multiple active of diseases, the active and also chronic diseases. Okay, acute and chronic. Acute tu maknanya people, those who are in hospital have the acute, for example the infection, but the chronic meaning that they have the NCD, okay, diabetic for 2 years, okay, and counting, hypertension. So all of that is the chronic. I hope at this stage you already know how to differentiate between acute and also chronic diseases. Okay, and older adult also have the age-related degenerative changes in terms of the physiological changes and also pathological changes, okay, related to the aging that interfere the eating behavior. For example, loss of teeth. Okay, that one is the physical, can limited swallowing inability. So that one is the degenerative. Okay, progressively generate lower down the ability to do something. Okay, so apart from that comes the limitation on the physical, lack of mobility, kan, and also they have their mental and also social function, limit in the mental and also social function. If mental, we refer to the cognitive ability to remind, okay, ability to do something, and also with that factor, the increased need for the rehabilitative. Okay, so it's more elderly in the rehabilitation center, especially for those who are limited in physical, psychological, and also social care, who are need help in terms of how to do in their activity daily living. Okay, so this requires a holistic approach how to avoid the partial ataupun complete loss of the independence. Okay, usually elderly without any support, okay, will stay at the residential residence, rumah orang tua kan, because they need care. Okay, they need the care in their home. They don't have any peluang to take care of them, so they just go sent to the rumah orang tua, nursing home for better care. Okay, so that's the characteristic of the older adults. Okay, so geriatric nutrition, the aim of the clinical nutrition for the elderly person compared to the younger is different. Okay, for younger population, the aim of the nutritional care is to reduce the morbidity, reduce the mortality, and so on. Okay, so but for the elderly population, the clinical nutrition is more towards how to improve the functionality. Okay, improve the quality of life. Okay, not mainly not the main priority is to reduce the mortality or morbidity. No, it's just to increase the quality of life and also increase the function so that they have the better quality of life. Okay, but the nutrition, clinical nutrition, yes, we provide the adequate amount of the energy, protein, okay, all the macronutrient and also fluid in order to meet the nutrition requirements. Then they can improve overall nutritional status. If the nutritional status improve, the functional status also will be improved. If the functional status improve, the quality of life also will be improved. Yes, that's the main goal for the geriatric nutrition. Okay, so nutritional challenges, okay, comes the malnutrition, overweight, obesity, and also dehydration. That's the common disease. We call it disease among the elderly. Okay, the common situation among the elderly. So you already know about malnutrition. Okay, malnutrition, it either become underweight or overweight. So in elderly kita ada dual malnutrition. The one group of the elderly who are undernourished, one group of elderly who are overnourished. Okay, so so malnutrition is redefined. Okay, apart from what I said, malnutrition have two categories: undernutrition, overnutrition. The definition of the malnutrition is revised by Aspen to cover these three components. So meaning that those who are malnourished come with the uncomplicated starvation, they are starvation. Okay, and also come with the chronic diseases or acute diseases or trauma. Okay, they have one condition of diseases, and this one is really important: social and also environmental condition that lead to the starvation related to the malnutrition. So comes the factor of the social and also environment. Okay, to prevent or to overcome the malnutrition later, okay, we need to take this factor, social and also environment, to improve the malnutrition status. Okay, because when you see in this definition, they come the factor of the social and also environmental. Okay, so there are two or more following 6 characteristics that have been identified to determine malnutrition. One, obviously, insufficient energy intake. Okay, inadequate energy intake will lead to the weight loss. Okay, and you also know if weight loss, not only weight, okay, they also comes the loss of the muscle, loss of the fat, okay, loss of the fluid. Okay, and also if they have loss of muscle, fat, and also fluid, so they will diminish the functional status. Okay, mainly functional status we measured with the muscle strength, Okay, hand grip strength, Nisa, this is your topic for your FYP, right? So functional status, usually we measure very easy by measuring the hand grip. Hand grip is measurement of the muscle strength. Why we use the hand grip? Because in our daily life, you want to grab something, we use our hands. Okay, we want to eat, we use our hands. So hand grip strength is really important. Okay, to make sure that the energy intake is sufficient. Okay, and also limit the support from others for eating condition among the elderly. Okay, so you need to remember these 6 characteristics of being malnourished: insufficient of energy intake leading to the weight loss. If you talk about weight loss, it comes the muscle loss, fat loss, weight loss. Okay, with these 3 conditions will lead to the decrease of the functional status as assessed by the hand grip strength. Okay, so talk about the malnutrition. So inadequate nutrition will contribute to the progression of the many diseases, especially all the NCD. Okay, but in elderly, so this one is really important, the sarcopenia and also the fertility. So sarcopenia meaning that in your body, so percentage of fat is increased compared to the lean body mass. Okay, lebih banyak fat compared to the muscle in the body. So that one is the sarcopenia. So fertility ni maknanya increase of the exhaustion, penat, inability to walk. Okay, and also come with the some of limitation, immobility and so on. Okay, so malnutrition have a close relation with the poor outcome. So come increase incidence of the infection and also pressure ulcer among the elderly. You need to remember that elderly, if they admit to the hospital, the hospital stay will be longer compared to the younger population. Okay, so longer hospital stay without proper management will lead to the pressure ulcer. Okay, so the pressure ulcer will increase the infection and so on. When you have the infection, obviously length of stay pun akan increase also. So duration of recovery after acute illness will be increased. So with that condition will increase the mortality. Okay, so people who assess at risk of malnutrition if their oral intake not achieve 50% of the requirement. Okay, so for more than 3 consecutive days. So that's why if you want to do study among the elderly, diet intake we measured more than 1 day. Okay, 1 day is not adequate to observe, to assess the intake. Okay, more than 3 days. Okay, 3 consecutive days is enough to measure to monitor the diet intake. So it's either way, not enough intake. Half of the requirement may be due to reduced ability to eat, due to the neuropsychological problem, immobility. If the patient have the chewing problem, swallowing problem. Okay, increase inability to eat, or increase the requirement whereby you have your energy requirement in increase, maybe due to the acute illness or infection or having the pressure ulcer. So that limit the elderly to capable to meet the energy requirement. Okay, there are 2 conditions. So whereby limit in food intake, not adequate due to the neuropsychological problem, immobility, or having the chewing or swallowing problem, or the energy requirement is increased due to the acute condition whereby they have the infection or pressure ulcer or so on. Okay. So this is the potential cause of malnutrition and suitable intervention that have been studied. Okay, elderly, potential cause of the malnutrition among elderly, yes, leading to the oral intake, factors that affecting the oral intake, for example, the chewing problem, dysphagia, swallowing problem. If they have the impact upper extreme function, so they the upper extreme function is inability to perform the food intake activity. So if the elderly have the restrictive mobility or immobility, they have the cognitive impairment, they are depressed, okay, loneliness, social isolation, or poverty, inadequate income to buy inadequate saving to buy food, okay, lack of food access. So acute diseases, this one increase the nutritional requirement, okay, and also some adverse effect on the medication, and also restriction of diet, okay, especially for those who are vegetarian, they do the restrictive, by doing that restrictive diet, some of the micronutrient cannot achieve the requirement, okay. So if you can see here, the potential causes comes the environmental factor and also social factor, apart from the pathophysiological and also physiological factors among the elderly. Okay, so the factor tu dia ada, they are multifactorial. So you need to identify when you manage the elderly who are malnourished, you need to find the root factor, the root cause of being malnourished. Okay. Okay, so enough for the malnutrition. So apart from the malnutrition, you have one population who are overnourished. Okay, so obesity, yes, comes with the negative health consequences. Okay, not only for the elderly, for all population, adult population pun sama. Okay, currently affecting between 18 to 30% of the elderly population. Okay, 18 to 30% of the elderly population are obese. Okay, and also either overweight or obesity. Okay, so another nutrition challenges among the elderly is the dehydration. Okay, older people are at increased risk of dehydration for various reasons. Okay, if they are dehydrated, comes the serious health consequences. Okay, so prevalence rate also low in the community of the adults. So prevalence of dehydration is low. So increase more than 1/3 in more fertile and also vulnerable adults. Okay, and also those who are in need of care. So those who are staying in the residential, who need fully support, that's the group who are prone to get the dehydration. Okay, so this is the factor, the cause of the inadequate drinks among elderly. Yes, first is the age-related physiological changes that increase the dehydration risk. So bila ada age-related physiological changes tu maknanya deria dahaga, the thirst, okay, dah threshold is reduced. Okay, and also elderly also have a lot of medication to take, polypharmacy, such as they may take the diuretic laxative, so which increase the fluid loss. Okay, so some of them have the memory problem, that forget to drink or forget they already drink, so they didn't know about the current situation. So some of them reduce their intake voluntary, maybe due to very rasa takut, inability to go to the toilet without any support. They have lack of support, so that's why they limit their drinks. Okay, because there are no one to help them to go to the toilet. Okay, so tempat yang paling selalu elderly jatuh adalah di toilet. Okay, because there are lack of support in the toilet. Tambah dengan the situation in the wet flooring, okay, in the toilet, leading may cause the fallen among the elderly. So the last factor is maybe the physical access to drink, okay, the provision of the drinks, the beverage. Okay, elderly have difficulty to reach the machine, for example, to boil the water. Okay, maybe they have the machine but it's very far to access the machines. Okay, that's the leading cause of the inadequate drinks among the elderly. Okay, so with that problem, malnutrition, obesity, and dehydration comes the nutrition intervention. Okay, most of the study already published in our journals, but in to counter the ethical aspect to do the nutrition intervention among the elderly population, first you need to meet their preference. Okay, so first you need to give them the oral nutrition instead of the product or TPN enteral product. First, the first choice is to give the oral. Okay, either the real food or by support with the ONS. Okay, so that's the first choice for the nutrition intervention among the elderly. So to provide the oral nutrition, yes, we need to counter the elderly will and also preference. So that one is the first priority. Okay, for example, the elderly doesn't like the chocolate flavor, so you need to take care of that limitation. Okay, that's their preference. Okay, how to meet okay, iklan. Okay, let's move on again. So this one, you already learned about NCP, nutrition care process?
Yes.
Yes, okay.
Yes.
So among elderly pun sama, there are no such a difference. So to manage the elderly, we as a dietitian, we use NCP. Okay, but apa beza the differences between nutrition care among adults and also elderly? So the elderly admit in the hospital, all of them need to be screened for risk of malnutrition. Okay, so the screening. Okay, the screening is the first step to screen on about the reduce of the nutritional status. Are there increased risk of the malnourished? They have the reduced intake or the increased need. Most of the screening tools that widely used in hospital for elderly population, we use the MNA. MNA. So MNA is a validated tools to measure the risk of malnutrition among the elderly. Okay, so for younger population, we usually use MAS2, okay, SGA, and so on. Okay, so yes, screen for the malnutrition if the elderly have a risk of to become the malnourished, then the comprehensive of the nutritional assessment needs to be done to assess the nutritional status A, B, C, D. A, anthropometry. B, biological. C, clinical. D, dietary. So that's the all the important component need to be assessed. Okay. So apart from that, after do the comprehensive nutritional assessment, are the elderly is malnourished? If yes, you need to do some intervention. Okay, so you need to do the ND, nutrition diagnosis. After that, what is your goal? What is the short-term goal? What is the long-term goals? The long-term goal, short-term goals need to reflect back your assessment. What actually the problem? Okay, is that the problem is intake? So that you need to come out with the test statement that reflect the intake. Okay, and then the goals need to meet, need to suitable with the ND tadi. If the ND nutrition diagnosis is on intake, so the goals should reflect back how to improve the nutritional intake. And comes the intervention, comes the monitoring, and so on. Okay, and then the screening you need to do in regularly. Okay, depends on the location of the elderly. If the elderly staying at the residential area, at care home, nursing home, so it's ideal to do it every 3 months. Okay, but if the elderly staying at their own home, okay, so at least once a year to re-screen the risk of the malnutrition. Okay, so I hope you know about the flow of the nutritional care of the older adults is quite similar to the younger population. Okay, so we go one by one. Okay, the nutritional care screening. Every older adults, if they are look underweight or overweight, all of them need to routinely screen for risk of the malnutrition. Okay, using the validated tools MNA. So MNA, they have the full form or short form, depend on your need, whether you want to use the short form or long form. So it need routinely screen at admission. That one is compulsory, okay, during admission, and also need to rescreen at the regular intervals every 3 months or once a year, depending on the location. So yes, you need to use the validated tools to screen for the malnutrition. So if the elderly after screening, you identify they have risk of the malnutrition, you need to do very comprehensive nutritional assessment. So this one actually to provide information for your nutrition therapy in your intervention. So what kind and the severity of the malnutrition, what are the leading cause of the malnutrition, so what actually the preference on the elderly, you can get the preference when you ask about the dietary intake, what actually the resources, the limitation on the food intake, maybe they have the chewing problem, swallowing problem, eating dependence eating. So all of that need to be assessed. Okay, so dietary intake monitoring, yes, should be monitored for the several days. Okay, not only for one day, because several days you can estimate the estimate the trend and also what actually the limitation to achieve the nutrition requirement. Okay. So intervention, patient need to intervene based on the problem, okay, that you already identified in the screening and also your assessment. So so when you want to intervene, so you work as a multidisciplinary, not only dietitian to intervene that malnutrition problem or that problem. So you need to do the multidisciplinary to include the doctors, the nurses to implement the planned care of the patient. Okay. So yes, after the intervention comes the monitoring. So all the intervention that you already given to the patient, you need to monitor at the regular basis whether your intervention have achieved your goals or not within the time that you already stated. Okay, so in case the patient you given the enteral or parenteral feeding, any early termination, you need to define. If the goal cannot be achieved, you also need to define and also improve in your documentation. So in the hospital setting, if your plan patient discharge, you also need to have the discharge plan. Okay, if the patient discharged with the ONS, what is your plan for patient to continue the ONS at their own home? So the plan during the hospitalization need to be able to continue, okay, after discharge at their own home. So you need to give all of plan of action before the patient discharge. Okay. So, okay, let's move on to the recommendation. So in this lecture, you will give some of tips how to decide the energy requirement, protein requirement, the fiber requirement, and all the macronutrient requirement for the elderly. So for the energy requirement, okay, for the elderly, so it's recommended to give about 30 kilocalorie per kilogram body weight per day, okay, for every patient. Okay, so regard to their nutritional status, if they are malnourished, so or underweight, BMI 21, so you can increase the energy prescription to 32 to 38 kilogram per body weight. So for the elderly, underweight is defined the weight below than 21. Okay, so the desirable body weight is up to 27. Okay, 21 to 27 is a normal body weight for the elderly. Okay, so kalau younger population 24.9, so that's the normal. So for the elderly, dia naik sikit 27. Yeah. That's the normal weight for the elderly. So for the healthy and sick older person, resting energy expenditure should be around 20 kilogram per body weight before you come out with the PAL and also PAL and also their own TEE lah, total energy expenditure. So usually the physical activity level for the elderly is around 1.2 and 1.8. So this one you need to assess when in the assessment the kind of the physical activity that has been conducted by the elderly. So that you need to decide whether 1.2 or 1.8. Okay, so enough for the energy requirement. Comes protein requirement. So for protein requirement, so at least 1 gram protein per body weight per day to be prescribed for the elderly. So it depends on the nutritional status, their physical activity, and also their disease status, and also the toleration levels. Okay, so recommendation protein intake of 0.8. Okay, so this one under discussion. So that one is not optimal level for the elderly. For the elderly, at least 1 gram of protein per kilogram body weight. So for the healthy older adults, it should be range 1.0 to 1.2. Yeah? And also in case of the illness, protein requirement may be further increased, okay, due to the inflammation, infection, or having wound or pressure sore. So this one you need to refer to the other MNT how to decide, but then should not be lower than 1.0. Okay. So protein requirement for frail and also very ill older adults, there are no evidence to prescribe the number for the elderly. So please use the range of at least 1.0. So for elderly who are with acute and also chronic illness, the protein requirement should be around 1.2 to 1.5. Okay, for those who having the severe illness, severe injury, and also severe malnutrition, so the protein requirement should be up to 2.0. Okay, so this one actually to ensure that they preserve the lean body mass. Okay, should prescribe the enough protein so that they can preserve the lean body mass and also their own body function, to maintain body function and also the health. Okay. For fiber requirement, so if the elderly on enteral nutrition, please choose the product having the fiber. Okay, enriched with the fiber. The fiber requirement for the elderly is similar to the younger population, is 25 gram. So 25 gram of fiber, daily amount of the fiber is adequate for the normal laxative. You need to bear in mind elderly have, apart from the dehydration, malnutrition, overweight, the other problem is the constipation. Okay, so to make sure that the elderly, to prevent the elderly from the constipation, there are three factors. One is the fiber intake. Second, educate drinks. Okay, at least 1.6 to 2 liter per day. And the third one is the mobility. Okay, so these three components, these three factors is really important to prevent the constipation and also to regulate the normal bowel function. So among the elderly, okay, so it's quite challenging to get the enough fiber. Is challenging to drink enough water, also challenging to be able to walk mobile for the elderly, also challenging. So that's why constipation is the normal health problem among the elderly. So for the micronutrient, so there are no specific deficiency of the macronutrient should be delivered according to the recommendation of the healthy older person. So the recommendation of the macronutrient should follow the younger population. Okay, there are no prescription, especially for the elderly. There are no difference macronutrient requirement between elderly and also younger adult population. But due to an increased prevalence of the gastrointestinal diseases, so elderly always come with the gastritis, poor absorption of the B12, calcium, and also iron. Okay, so usually this deficiency will be corrected with the vitamin and also mineral supplementation. Okay, so now comes the recommendation for those who are malnourished and also at risk of the malnutrition. So in this guideline, they come out with the social factor and also environmental factor, how to prevent and also overcome the malnutrition among the elderly, especially those who are in the hospital and also in the residential home. Okay, so they recommend to provide and also to offer the mealtime assistance for those who are need the support. Okay, the support may be need ranging from the adequate position. So position with eating, they need help to position the eating at the table, or direct physical assistance, maybe to cut off the meat and also the rice, to bring all the food on the spoon, from the plate to the mouth. So it depends on the needs and also the limitation of the elderly. So those who are living in the institutional, so they need to improve the environment by given the home-like situation, the pleasant dining environment. Okay, so that will increase the food intake among the elderly. So comes the requirement for the music during the meal time. Okay, so environmental factor may play an important role for the atmosphere during the meal time. So among them, eating location. You want to eat kat mana? Dekat dining room, dekat at the bed atau at your room. So depends on the elderly. So what kind of the furniture? Maybe better furniture will lead to the better intake. So depends. Meal companion, eating with others. Okay, ambient sounds, ambient odors, ambient temperature, ambient lighting. All of this is really important. How to make the dining environment more pleasant to those who are living in the institutional. So you all faham tak institutional tu apa? those who are at rumah orang tua, okay, nursing home. So in the institutional setting, yes, we can provide that requirement, okay, but in the hospital it's really hard, okay. But some study have did the intervention by improving the meal environment, but there are no significant changes of intake, okay, among elderly in the hospital setting. So that's why that approach is not effective in hospital setting, but in the institutional setting, yes, you can do that. They are more cost effective. So the elderly with the malnourished or at risk of malnutrition should be encouraged to share their meal time with others. Sharing with others, maybe using the same plate or eating using the tray, kan, ataupun companion during the eating. That's what is really important. So it will stimulate the intake and also will improve the quality of life. Okay. Am I too fast?
Just okay, Dokter.
It's all good.
Okay ya. Okay, faham ya?
Paham.
Okay.
Faham.
So, okay, thank you very much. So, in Malaysia, we didn't call Meal on Wheels, but tapi kita panggil apa, food delivery. Food delivery to those who are living in the home dwelling older person who are malnourished. Okay, so should be high dense and also include the meal to support the adequate dietary intake. So these services in Malaysia is not fully covered in all area. Okay, maybe dekat Kuala Lumpur je ada. Okay, so mean always maknanya food delivery, food will deliver to elderly homes, elderly who are malnourished that already identified by the district nurses. Okay, so they will deliver the meals, okay, that covers for 3 main meals per week. Okay, so the meal that provide for the elderly should be energy dense and also nutrient dense. Okay, elderly person with malnutrition and also risk of malnutrition should be offered nutrition information and also education. Okay, as part of the comprehensive intervention. Okay, some of us think that there are no need to give counseling for the elderly. They are not effective. Okay, very hard to change the behavior for the elderly. But study have confirmed by giving the nutritional information and also education, okay, can improve the awareness and also the knowledge on the nutrition problem and how to promote the adequate dietary intake. Okay, so yes, you need to provide the counseling and also education to those who are malnourished and also at risk of the malnutrition. So not only to give the knowledge and information to the elderly, you also need to include the healthcare professional, especially the caregiver who take care of the elderly, to give the nutritional education, okay, to ensure that they also have the awareness and also basic knowledge on the nutrition, what actually the nutritional problem and how to promote the adequate intake. Okay, so in your strategies for the elderly population who are malnourished, you also need to include the caregiver, okay, in the management, in your intervention. Okay, the caregiver is up to the resources, maybe the family members, maybe the spouse, or maybe the healthcare professional that been hired by the patient. Okay, so you need to include them in your intervention as well. So selain daripada to increase the support, the environment, so comes the role of the nutrition counseling. Okay, so those who elderly who are malnourished should be offered the individualized nutrition counseling. Okay, apart from the education tadi, you also need to provide the counseling. Okay, so the counseling should be at least 2 individual session. Okay, sekurang-kurangnya 2 session individual, or you also can combine in a group session, or if patient is discharged from the hospital, how to monitor after that you can do by the telephone contact or using a written advice as a discharge plan to your patient. So this one should be maintained over a period of time. Okay, when patient discharged, maybe the community dietitian domiciliary provide the domiciliary services. Okay, they will do the monitoring and also reassessment later at their own home. Okay. So apart from the counseling comes the role of the food modification. Okay, so elderly should be offered the fortified food, okay, to support the nutrition intake. So this one very good for those who having the chewing and also swallowing difficulties. Okay, enriched with energy dense, enriched with the protein, okay, enriched with all the vitamin. Okay, so additional snacks and also finger food as a snacks, okay, also is a good idea. It's a good strategy how to increase the energy intake and also protein intake between the meals. Okay, so those who are having the chewing and swallowing difficulty, the texture modified food, okay, is really important to compensate the functional limitation so that the elderly will get the adequate energy and also protein. Okay, so texture modification can also make the swallowing process slower and also safer. Okay, for the elderly. So older person who have risk or sign of the dysphagia. So sign of dysphagia need to be assessed by the OT, occupational therapist. So to those who having the chewing difficulty problem, the texture modification, and also to offer the enriched food, okay, as a strategy. Okay, so they call it as a good clinical practice to offer the modified food as a compensatory strategies to facilitate the intake of food, especially to those who are having the dysphagia problem. Okay. Okay. Apart from the food modification, okay, comes the role of the ONS. Okay. Ingat, the first priority adalah to give the oral food. Okay, oral food is a real food. Okay, if the real food doesn't meet the requirement, then you can offer the ONS. Okay. So those who are malnourished or at risk with the chronic condition should be offered the ONS. Okay. So if the intake is not meet the requirement, okay, the ONS can be given to the elderly, those who are high in protein. Kalau high in protein, the characteristic is the protein inside should be more than 20% of the energy. And also high energy too, meaning that they have 1.5 kilocalorie per meal. So that one is the high energy. So kalau isocaloric maknanya 1 kilocalorie per 1 meal. Okay, that's one is the isocaloric. Okay, for the elderly, we always choose the product which are high protein and also high energy, because the elderly have the limitation to finish the drinks. Kalau you tak choose the high energy, okay, banyak yang wasted. Okay, because they are not able to finish the drinks. Okay, so the drink should be high energy dense and also protein dense. Okay. Hospitalized older person with the malnourished should be offered ONS in order to improve the dietary intake and also body weight, and to lower risk of the complication and also readmission. Elderly ni ada the risk to readmit in very short time is really high. Okay, maybe poor nutritional will lead to the high infection. With having another infection within no time, you will readmit with a short time. Okay, so by given the ONS, okay, the weight gain will be greater. Okay, and the number of the falls will be lower in those who are provided ONS by the dietitian group, rather than only dietitian without ONS. So with ONS, diet consultation plus ONS, you can see the weight gain was greater in that group compared to the dietitian advice only. Okay, so so for those who are already offer ONS, so they should also offer ONS after discharge from the hospital as well. Okay, and the duration and the prescription for the ONS is at least 400 kilocalorie per day. And also they have the protein, about 30 grams of the protein per day. That one comes from the ONS. Okay, so the ONS should be given at least 1 month. If you discharge, you need to supply and also to provide the ONS for the elderly after discharge for 1 month. Okay, so that baru ada effective. The ONS is effective. Okay, so in order residents of the long-term care, energy intake increased 30% with snack food compared with 50% by ONS. If you provide the elderly with the food modification tadi, you provide extra snacks, so you can see about 30% increase of the diet intake. Okay, if you give the elderly the ONS at least 400 kilocalories with 30 grams of the protein, you can see about 50% of increase of energy intake. Okay, so in older malnourished care home subject, ONS result in higher energy and protein intake and also better quality of life compared to the dietary counseling only. So ONS actually is really effective in managing malnutrition, okay, but it's really cost. Okay, if the cost is not the limitation, the elderly have the budget, there are no financial constraint to buy and also to supply the ONS, then that will be the first priority. Okay, if the financial is the limitation, so diet counseling ataupun providing snack also can give penambahbaikan lah, to give the effectiveness in terms of to increase the energy intake. Okay, but the ONS will be the first option. So community or nursing home, okay, ONS be proposed or when the dietary counseling and also food fortification is not sufficient to reach the nutritional goals. Okay, so selalunya ONS ni we give the last option because the price, because of the financial tadilah. Okay, selalunya dia akan provide the counseling, after that we give the food fortification, additional snacks. Okay, if the counseling, additional snacks, food fortification doesn't improve the food intake, doesn't improve the malnutrition, then the final step is to provide the ONS. Okay, so if you provide the elderly with the ONS, you need to check for the compliance. So regular monitoring to check on the compliance is really important. Okay, so apart from the compliance, you also need to assess on the patient taste and also eating capacity. If the elderly can manage to complete the drinks within 2 hours to complete 400 kilocalories, You need to measure all of that. Any changes, you need to record. Okay. So older malnourished need the higher energy supply than the younger adults to gain weight, okay, and increase in body weight and fat-free mass in response to the energy supply is lower compared to the younger population. In elderly, you provide a lot of energy, the same energy compared to the younger population, the similar energy, but the weight gain is lower compared to the younger population. Okay, because the pathophysiology of the elderly is slowing down. Okay, it takes time to increase the weight. To show the effectiveness compared to the younger population. Okay, and then the compliance of the ONS in the community is higher compared to the hospital. Okay, in the hospital they have another factors, maybe some stress or distress, some procedure that limit to comply with the ONS. Okay, but in the community, those living in the care homes, okay, the compliance with the ONS is higher. Okay, so finish with the malnutrition and risk of the malnutrition. Any question, class, before we proceed with the underweight and also obesity, overweight and also obesity? Do you have any question to ask?
Doctor,
Hmm?
I have a question regarding meal suggestion for the elderly.
Okay.
Can we suggest a soft diet or liquid diet for the elderly?
Okay, you can suggest the soft diet, liquid diet for the elderly, but you need to assess them first. Assess the swallowing ability, chewing ability. If the OT already assessed and then they already indicate that which level of the consistency, then we as a dietitian, we need to prepare. Dia ada consistency pula. Is it liquid, honey-like, okay, ataupun nectar? So which consistency? So that's our role to prepare the meal. Okay, do not simply, okay, oh, elderly, so soft diet. No. So you need to offer the normal diet first and then assess the intake, assess the problem. If they have the problem to eat the normal diet, then you can change, okay, depend on the need that you already assess. Okay, if they prefer soft diet, maybe bubur compared to rice, so then you can change. Okay, if they are not able to finish due to not able to swallow ataupun not able to chew the rice is really hard to telan, so you need to change that to meet the elderly preference and also capability to finish the diet tadi. Okay, Haikal?
Okay, thank you, Doctor.
Any other question, class? No question. We proceed with the overweight and obesity. Okay. So, management of overweight and obesity among the elderly is different compared to the younger population. Okay, kita tengok tadi, the role of the geriatric nutrition is to increase the functionality and also to increase the quality of life. Okay, there are no diet restriction. There are no requirement to reduce the weight for the overweight individuals. Okay, so I recommend that weight reducing diet shall be avoided for those who are overweight person. So like I said before, the normal weight for the elderly is 27 and below. 21 to 27 we consider as a normal or desirable BMI for the elderly. In fact, BMI also is not the indicator of good nutritional status. Kita tak tahu the body composition. Okay, so in elderly we have the sarcopenia. Sarcopenia meaning that okay, elderly weight 80, but the body composition, okay, when you do the BIA, you can see the differences on the body composition. There are a lot of fat compared to the muscle, kan? But with that component, body weight tetap sama, 80, kan? 80 older elderly and 80 younger population will be different. Maybe younger population, there are a lot of muscle compared to the fat. Yeah, so for the elderly, they may have the sarcopenia, even they have a good BMI. So the body composition does matter compared to the BMI tadi. So for the overweight, there are no recommendation to do the weight reducing diet. Okay, so there are no weight reducing diet for those who are overweight. No need to lose weight, okay, according to the meta-analysis. So because those who are underweight have a better lowest mortality rate compared to those who are having normal weight and also underweight. Those who are overweight have lower risk of the mortality. Okay, so weight loss, whether intentional or not, so enhance the age-related loss of the muscle. If elderly have the weight loss, we didn't know whether yang loss tu adalah fat ataupun muscle. Most of the time will be the muscle. Okay, muscle will lose first. Okay, so if loss of muscle, they have the consequently increased risk of the sarcopenia. Okay, if have very limit amount of the muscle inside the body, can cause the fatigue, very lethargic, not able to walk, and lead for the functional decline and also fractures. Okay, easy to fracture. Okay, because yang ada dalam badan tu adalah lemak saja, no muscle at all. Okay, easy to fractures and also malnutrition. So the common weight regain after weight reducing diet, okay, predominantly regain in fat mass rather than lean mass. So lean mass takes time. With the exercise, you can build the muscle. But the elderly, they are very limited chances to build the muscle. So maintaining the muscle is the main priority. So they're not supposed to losing weight for those who are underweight. Overweight, sorry. So they are recommend to have a combination of the well-balanced, nutrient-rich diet, okay, providing adequate amount of the energy, protein. Then also need to do the physical activity to stabilize the weight. Maknanya weight need to be stable, tak akan naik, tak akan turun. There are no yo-yo weight. So if they reduce the weight and then they regain the weight regain mostly from the fat. So they recommend to maintain the weight, stabilize the weight with a balanced and also nutrient-rich diet, and also needs to do the physical activity. So, but in an obese person, older person with health problem, they have the health problem, especially orthopedic problem. With the obese, their limit to walk maybe due to sakit sendi, kan? So the weight reducing diet shall only be considered after careful and individual weighing of the benefit and also risk. Okay, positive effect of the intended weight loss on the orthopedic problem. Okay, and also yes, the patient need to reduce the weight due to their cardiovascular disease and also metabolic disease because of their diabetes. Okay, and also inflammation. And with the diabetes comes the functional limitation. Yes, they can consider to do the weight reducing diet. So, but you need to bear in mind not only from the diet. So they need to do with the combination with the physical activity. The physical activity is really important for the muscle. muscle building. So weight loss from the diet, build again the muscle from the physical activity. So benefit of the intervention, you need to consider the functional resources, the metabolic risk, the comorbidities, the patient perspective, and also the priority. That the main important thing is the quality of life. So is it advisable to aim at the weight stability and also to avoid the further aggravation of the obesity. Tak nak ada penambahan berat badan. So when they are obese, there are no health problem. So it advised to maintain the weight. Okay, do the weight stabilization rather than to reduce weight. If the patient have the weight-related health problem, yes, they can do for the weight reducing, but need to do with the physical activity level after consideration of the benefit and also the risk. Dietitian will consider that. So if the weight reduction is considered for the obese person, so energy restriction will be only moderate. Maknanya aim for 500 kilocalorie less than the requirement. So that meaning for the moderation. Moderation is about 500 kilocalories less than the requirement. So the aim for the weight loss is about 0.25 to 1 kilogram per week. So you need to reduce about 5 to 10% of the initial body weight for the 6 months. There are no drastic weight loss. So the aim for the weight loss is about 0.25 to 1 kilogram body weight per week. Okay, so within 6 months. Okay, drastic weight loss, okay, itu adalah kehilangan fluid and also the muscle. So yang tu kita tak nak. Okay, so you also need to assure that the protein intake for the weight reducing tadi adalah not at least 1 gram per kilogram body weight. So this one for the muscle maintenance. Okay, so strict dietary regimes like diet with very low energy, less than 1000 kilocalorie, or very low calorie diet and very low calorie diet is strongly discouraged for the elderly. So because this one may lead to the malnutrition and also functional decline. Ingat bila ada drastic weight loss, they will lead to the limitation of the function, very easy to fall down, and then may lead to the mortality. So that one we need to take care. Okay, there are no drastic in losing weight. So if the weight reduction is considered, so the elderly also need to reduce about 500 kilocalorie per day tadi, plus physical activity levels. So they need to do the exercise. Okay, need to combine moderate energy reduction tadi 500 kilocalorie with the exercise about 2 to 5 times per week. Okay, 45 to 90 minutes per day. So you need to combine with the flexible, endurance, and also resistant training. So this one, the aim is to maintain the functionality of the elderly. Okay, kita nak maintain the functional status. We want to maintain and also stabilize the lean body mass. Okay, so faham tak for the elderly and also for the overweight and obesity? Faham ya? So there are 2 categories, overweight and obesity. Overweight, there are no weight reducing diet, aim for the weight stabilization. Okay, for the obese, okay, without health problem, other health problem, they should do the weight stabilization. Kalau with the health problem, they need to do moderate energy restriction, plus with the physical activity levels that have the 3 types tadi: resistant, endurance, and also flexibility 2 to 5 times per week. So 45 minutes to 90 minutes per day. Yeah. So now is the last section for today's lecture is how to prevent dehydration. So dehydration, every elderly have a risk to become dehydration. Those who are at risk yang kita dah bincangkan tadi lah, they have the physical limitation, loss of access, loss of age-related dehydration, reducing the thirst levels, okay, voluntary limit the drinks tadi, okay. So what actually the recommendation to overcome dehydration among the elderly? So the intake should be around, for women is 1.6 liter per day, okay. For the men, about 2 liter per day. Okay, unless they have the different clinical condition like a renal disease, liver disease, ada edema, ascites, that one you need to take notes. Kalau ada ROF pun sama, you need to consider that restriction of weight, so you need to consider that. But in general, intake should be around 1.6 per liter for women and 2.0 liter for the man. So any type of drink is depends on the elderly. If the elderly likes to drink coffee, so the coffee will be counted as a requirement tadi, okay, to fulfill the choice of the drink should be follow the preference. Kalau dia suka susu, then we offer susu. Okay, kalau coffee, we offer coffee. Tak ada bad drinks. Even kalau dekat kalau di Western country pun they even offer the alcohol with the proper amount. Okay, so assuming that, okay, the recommendation for the educate any drinks adalah about 2 liter for women and 2.5 liter for men, okay, with the combination with the water, beverage, and also food. But from that value, 22 liter for women, 25 liter for men, 80% of that requirement should come from the fluid, should come from the drinks. So that's come the recommendation of 1.6 liter for women, 2 liter for the men. So all other person should be considered at risk of low intake of the fluid, and also need to encourage to consume adequate amount of drink. So in hospital, yes, kita ada IO chart, berapa amount fluid intake, berapa yang in, berapa yang out. We do the proper monitoring. But those who are living, free living in the residential, so the management need to come out with the SOP, how to monitor the intake, and also how to make sure that the provision of the drink tadi is accessible to the elderly. Accessible meaning that not only in a good distance, it's very easy to get, okay, maybe comes all the support from the staff to give the provision, maybe every 3 hours comes the water provision, water supply. Okay, so that's SOP, especially those living in the institution need to implement in the institution. Okay, so class, itu saja lecture hari ini. I open for the question. Do you have any question to ask regarding geriatric nutrition in our topic malnutrition, obesity, and also dehydration?